Cardiovascular atherosclerotic disease is a chronic inflammatory disease. So, coming to the epidemiology of the cardiovascular disease, is the leading cause of death globally, almost 31% mortality, and in India also probably it is one of the leading cause. And 12 to 16% of coronary artery disease patients are young, that is less than 40 years. So coming to cardiovascular risk in 21st century, one of the most important risk factors of cardiovascular disease is, we know, diabetes is one of the most important risk factors. If the patient is having diabetes, his chances of having cardiovascular disease will go by 3 or 4-fold higher. And high lipids, high LDL cholesterol, high triglyceride, low HDL also is very strong predictor, a strong risk factors for cardiovascular heart disease. Hypertension, very strong predictor of cardiovascular heart disease. Hemostatic and thrombotic factors also, and of course behavioral factors like sedentary lifestyle, smoking, and lack of exercise are very important. And certainly demography is also important because we Indians have a tendency to get cardiovascular disease 10 to 15 years earlier than the Caucasian counterparts. So I think our gene is also a bit defective in that point of view. So genetics is also very important, and cardiovascular disease, as we know, can be seen to run in families. So coming to risk factors of cardiovascular disease, 60% of those who develop coronary events have only one or even none of the traditional risk factors. So how they are developing this cardiovascular disease if they don't have any risk factors or only one or few risk factors? So here comes the role of chronic inflammation. So chronic inflammation nowadays is a very burning topic and very talked about topic nowadays. So more than half have either normal or mildly increased lipid value, but still they are having this cardiovascular disease. So here comes the role of chronic inflammation. Coming to, and one of the most strong predictors of chronic vascular inflammation is C-reactive protein, HSC reactive protein, that is highly sensitive C-reactive protein. And here, as we can see, whatever the Framingham estimated 10-year risk, at the same level of 10-year risk of Framingham risk category, if the C-reactive protein level is high, the relative risk of getting cardiovascular disease is high. Similarly, whatever the level of low density lipoprotein, low density LDL, whatever the level is, if the C-reactive protein in that level is high, the relative risk of getting cardiovascular disease is high. So how the statements of the leading guideline makers have changed over the time, that in 2003, AHA said that measurement of hs-CRP may help direct further evaluation of therapy in primary prevention of cardiovascular disease. The entire population should not be screened for hs-CRP for purpose of cardiovascular risk statement. But in 2010, ACC-AHA said measurement of CRP is in apparently healthy people to identify cardiovascular risk. And in 2013, ACC-AHA said that use of hs-CRP is for stratifying the high-risk patient for atherosclerotic cardiovascular disease. So coming to the vascular inflammation, how the vascular inflammation is happening, the activated monocyte enters the tissue through endothelium. Similarly, LDL enters the tissue through endothelium, and LDL gets oxidized and release the inflammatory triggers. These inflammatory triggers converts the monocyte into the macrophages, and nuclear factor kappa B and other inflammatory mediators PPAR gamma etc. are activated, and nuclear factor kappa B pathway and kynurenine pathway is activated, and thus inflammatory mediators like C-reactive protein, CD40, CD40L, tumor necrotic factor alpha, interleukin 1-6 are released and platelet gets activated. And many adhesion molecules like VCAM1, ICAM1 are released, and a vicious cycle of inflammation is set. So defense mechanism against inflammation are like we can stop the kynurenine pathway through 3-hydroxyanthralinic acid modification, and we can also inhibit the nuclear factor kappa B pathway. Presently, we have options of intervening at the inflammatory stage by giving statins, by giving PPAR gamma, thiazolidinediones, by giving antiplatelet agents. And the novel therapies are like tryptophan metabolites, for example, 3-hydroxyanthralinic acids modification, and nuclear factor kappa B inhibitor like curcumin. As already has been told that nuclear factor is in an inactive form in cytoplasm. It is an enzyme, and whenever there is inflammatory stimuli, the kinase enzyme acts on it and makes it active. And activation of nuclear factor kappa B occurs, and then nuclear factor is translocated into the nucleus, and thus release of inflammatory mediators like tumor necrotic factor alpha, interleukin 6, interleukin 1 beta, HSCRP etc. occurs. Also release of adhesion molecules like ICAM and VCAM occurs. So here curcumin mode of action is that it prevents the activation of nuclear and also inhibiting the retarding the process of diabetic nephropathy also. So it also decreases fasting blood glucose, hemoglobin A1C and insulin resistance. Coming to kynurenine pathway, which is also an important pathway in vascular inflammation, here the tryptophan is metabolized to various inflammatory mediators, and one of the most important is 3-hydroxyanthralinic acid, and it has anti-atherosclerotic effect and reduce LDL. It is intermediate metabolite in tryptophan when metabolized through kynurenine pathway, and in macrophages 3-hydroxyanthralinic acid can inhibit activation of nuclear factor kappa B, activation of inducible nitric oxide synthase and interleukins stimulation, and it also reduces the uptake of oxidized LDL by macrophages and prevent formation of foam cells. So 3-hydroxyanthralinic acid affects the many genes related to lipid metabolism, and it thus modifies the catabolism, nuclear receptors, clearance and efflux related genes of the lipid metabolism. It has some clinical effects also on plasma lipids, like it significantly reduces plasma total cholesterol level, reduces triglyceride level, increases HDL level and decreases VLDL level. So 3-hydroxyanthralinic acid significantly decreases the plasma lipids by 1/3 to 2/3 levels. It has effects on vascular inflammation also, that it significantly reduces the infiltration of CD4 cells in atherosclerotic lesions, and it has significantly reduced the inflammation, and there is 80% reduction in atherosclerotic lesions. So in summary, 3-hydroxyanthralinic acid is an intermediate metabolite of kynurenine pathway, that is tryptophan metabolism. It has significant benefits like improves lipid profile and reduces vascular inflammation. Other targets are, newer targets are like succinylbucol and others, but they are on very trial stage, phase 2 or phase 3 trial stage. So in conclusion, despite optimal therapy with current drugs, still 1/3 of lower risk individuals with 0 to 1 risk factors have been known to develop atherosclerotic cardiovascular disease. Controlling inflammation will help improve cardiovascular outcome and may also help reduce morbidity and mortality in patients of cardiovascular disease. Thank you.